Welcome to this episode of Let's Talk, where we focus on the practical applications of some of the most talked about sessions here in the Monaco Congress. In this specific episode, we talk about the first global consensus guidelines in implant dentistry, specifically for edentulous patients. My name is Gerrit Heijkoop, and I'm very honored to be joined by the chairs of that second plenary session, Hom-Lay Wang and Frank Schwarz. Frank, Hom-Lay, welcome.
Hello, welcome.
Yeah,
welcome.
Thank you.
Let me say and start with a congratulations. I think this session came after a lot of hard work by many people, but for those who just tuned in, maybe we should start with the basics. The Global Consensus for Clinical Guidelines, the GCCG. Why was that initiative originally started?
You know, it's very interesting. I think Frank knows that very well. Ronnie Yoon and I, about 3 years ago, when we are in one of the consensus, which is the ITI consensus, we talked during the lunchtime and saying maybe we want to create the global voice. And so together, then we talked to the Frank. And so three of us kind of co-initiate this global clinical consensus guideline, which is a GCCG. That's a term, which is sometimes it's kind of confused. But then we trying to pick up a topic, and I think three of us was thinking about it. And you know, I'm always looking for the most standard and less controversy to begin with, and also one of the most demanding clinical scenario, and which is the edentulous maxillary area.
Exactly.
And so, as a Frank probably know more than I did, is when we get into the consensus, we're starting to learn more about such a simple things are not such a simple things. There's no simple things. It becomes a more discussion, more effort, and it's actually a great learning experience. And that's why we're using this podium to share with all the EAO members of what's new, what is coming, and what's the future.
Exactly. We'll dive into that in a second. Edentulous patients, one of the most demanding cases, a global initiative. Frank, can you share a little bit about how these guidelines have come about?
Yeah. So looking back at the EAO consensus meetings, which were very successful, but in what way? So how do you measure the success of a consensus meeting? And it's at the end, the dissemination. So does it really reach the practitioner in South Korea, in Southern Australia, or is it just within the EAO network? And that was apparently not the case. So we did not reach out to the people that are not at that educational level. And the second target group is, of course, we're doing it for the patient. And the patient needs to be informed as well. So these are two missing items, and that's why we have built this idea of a global consensus, looking at each and every country, continent, to have the major players, the most significant outreach, to take part.
Exactly. So many representatives from all over the world are part of this initiative. Now there's a first piece of paper, a first result of this process. Let's dive into the content of that. Can you describe a little bit what these first guidelines look like? What can people expect when they actually open them?
It's actually very exciting, and in the first spatial issue, as Frank and I try to put it together with all the effort from all the scientific co-chair and task force. Basically, we have a summary paper to talk about all the 6, starting from the diagnosis and the treatment plan, the patient selection, diagnosis, treatment planning, treatment complications, and to the maintenance. In each guideline, we have patient report outcome measures. We have a clinician report outcome measures. We have each things we vote on it, and we have achieved the consensus of what kind of recommendation we have. And then so we put that together in we call it umbrella paper. Then in each working group, we have the consensus paper based upon their group discussion and voting process.
Exactly.
So it's a very exciting, and together with another 7 paper from the survey and also from the definition of what is we call it prompts or CROMs, which is the patient reports outcomes measures or the clinician report outcome measures. So we have that to guide the readers to understand, and it all based upon the surveys and also the systematic review we have conducted.
Exactly. So it starts with very well defining what are the measures that we will measure in order to actually determine whether we are moving in the right way, both from a patient perspective and a clinician perspective. That's very innovative, I think. Obviously, we cannot dive into the entire content of this entire first guideline, but Frank, what are some of the highlights that you will think will really make an impact in the clinic?
Well, this is too comprehensive. Yeah, you cannot just focus on one or two highlights. But I think, as Hom-Lay has just mentioned, the highlight is that we have found a way to condense all these very complex information into a decision tree. Yeah, and the decision tree is on a Monday morning. You have a problem, you have to plan a case, and you don't have the time to read 20 papers.
Exactly.
That makes you crazy. And at the end, this was the main, I would say, the merit of this consensus, to find a way to visualize it, to provide a decision tree, where, as Hom-Lay has said, for each and every step of a workflow, the clinician can easily follow a checklist, like a pilot, right?
Yeah,
Before
exactly.
you start, you make sure that everything is in place.
This sounds like a amazing promise. Was it in fact that easy to make that most demanding case of the indentured patient fit in a relatively simple decision tree and checklist?
You know, as Frank and I was always joke around, we hope it's that easy and simple, but it's not.
Of course not.
So I think one, it's very important is just to follow up what Frank said. It's not only for the clinician, but also for patient.
They can actually follow
They can
what
follow
the
too.
choices the clinician is making.
And they can actually say what they want. So this type of things you can have even in the e-checklist, like the physician, you go to see the doctor, they ask you all these questions, and we can have that e-check-in. So the patient, before they go see Frank, and Frank can say, you finish this form, what do you want, what type of things, and so the patient expectation we know, and then we can follow that either way of the decision tree, and we can nominate, and the patient can actually see it through. So it's a very good tool not only for the dentist, but also for patient and also for we call it stakeholders.
Exactly. I can imagine as a patient, perhaps living in an area where my medical standards are not so advanced, all of a sudden via the internet, I can now reach to this decision tree, take it actually to my dentist, and be a co-partner in the treatment planning, right?
Exactly.
Is that the vision?
Yeah, this is what we call shared decision making. Yeah, so the decision is not just made by us. Of course, we have the competence. We have to inform and advise the patient, but we cannot push him in a direction which is completely outside of what we could define in this guideline. Yeah, so the patient is part of the game.
Yeah,
and let me add one further point. Well, implant dentistry, it's a fun thing. It's something that we all love to do.
Yeah.
But we should not overdo it, right? There are more options than implants.
Yeah.
And this became also part of an implant-related guideline not to place implants.
Even in a fully edentulous maxilla.
How is that?
That is, I think, relevant, judging by the amount of conversation in this Congress also, that there's more saving teeth first, and there's other options as well.
Yeah, or going for alternative ways, a conventional denture, not supported by implants. And there is also a clear pathway on how to come to this decision.
I can see how that's very beneficial.
Yeah.
Was there anything, because you had a meeting with over 125 experts from around the world to make this first consensus meeting, anything out there that really surprised you? And again, Frank, I'm aware it's a comprehensive thing and we cannot pick highlights, but still, I want to get some nuggets to see if we can spark curiosity.
Yeah. Hom-Lay, what was your personal highlight? So maybe from that
Or surprise, or like, oh.
You know, as a periodontist, I probe every single implant. And I think that's a straightforward things. And I always think that if you don't probe, you cannot identify disease. But soon I understand when we probe the maxillary reconstruction, either by implant or by for sure it's by implant, not by...
because otherwise it's not fixed.
There's nothing.
Yeah.
So if you have that implant-supported prosthesis, sometimes it's difficult to probe. That can be due to the surgical misplaced, or the prosthesis make it difficult for the probing. So a lot of people looking in maxillary edentulous area, they don't think probing is essential because they cannot probe, or even the probe may not be accurate. Mm-hmm. But this is different than in the partial edentulous. We always probe.
Yeah.
So in this kind of the content, we have a huge discussion, and that's come to me as a surprise, as a periodontist. That's a simple biological concept. But when you go into that content, people always think about how can you probe, how accurate they are, can you get access, which sometimes we don't think about it.
Uh-huh. So you say there was a personal learning or surprise that probing is an issue, in this case even of controversy, but it really depends on the case you talk about, right?
Yeah, it really depends on the case. And that, I think the message will be more clear in the publication so people can understand it more.
Exactly.
Yeah.
Frank, anything that raised your eyebrows during the process?
Yeah, well, I would say I've learned a lot. Yeah, and this is, I would say, the thing that each and every expert learned basic things from other disciplines. And for me, as an oral surgeon, I look at, of course, at the edentulous maxilla primary from the perspective of tissues. So is there bone? Is there soft tissue? Where can I put my implants? Go where the bone is. Yeah. And if there is not the bone, we build the bone and we place the implants. But the restorative component is so overwhelmingly important.
Especially in a full arch.
Especially in a full arch case. So all the perspectives from the prosthetic colleagues, they clearly changed my mind. So plan first. And this is not just a term, yeah? So what does it mean? Plan the restoration first. Try-ins, mock-ups, wax-ups, try-ins again. Come to the guided part that you have a template. And this is something in the workflow, and the extent was not that clear to me before.
Nice.
And I learned a lot, and now I see myself as a surgeon as not being the leader in the planning. Yeah. And this becomes apparent when you look at the decision tree.
Yeah, I think this is a very important aspect. I think as a surgeon, which Frank said, we needed to consider other counterpart, either prosthodontics or general dentists who construct this prosthesis. And we need to think from their aspect too, not just saying I can place implant here. Yeah. It does not mean I can place implant here or there. Can we make the prosthesis patient want? Exactly. That's the key.
Exactly. Yeah. Now you say the key driver for creating this whole piece is dissemination. Well, not the driver, but one of the reasons why it occurred. Can we disseminate this kind of knowledge easier further to more people around the globe? The paper is now there. The first presentation is out. What is needed to actually make sure we reach the south of Australia and beyond, right? What are the next steps?
Yeah. So the paper is not yet out. So they are supposed to be published definitely before the end of the year. But this is the first wave of publication as we have defined it. Yeah. So the scientific papers are out, the supplement with 20 papers and the umbrella included. But the dissemination is the second wave. And we have two strong partners, publishing partners. One was Wiley for the scientific part, and now Quintessence. They take care of the dissemination. So how can this be done? So we go, and that's why the partners are so important. In each and every contributing country, we have, of course, strong scientific partners, societies, and they go down to the level of publishing case reports, let's say, how to apply.
Very relevant.
Exactly. These, I would say, condensed information and data into how to do information. And this will be published in Quintessence journals in order to really reach the broadest possible readership.
Exactly.
So 2 waves of publication.
Exactly, that makes total sense. And I think anybody watching this, they probably have an interest. So they should be part of this and support that and share this message to anybody you can. Hom-Lay, from a scientific perspective,
No, I think in the publication, that 20 publication, we also highlight the gap exists on this, the consensus. And we understand there's nothing called perfect. There's always has a room for improvement. So we actually highlight a couple area and bring up the gap, which future researcher can work on it. The research will take some time to catch up,
of course,
to understand what we do, okay? And I think at least we provide the opportunity for all these people to work together to solve the issues. And so,
what is the biggest gap that needs to be worked on first? I mean, we have scientists watching. Where do we need future research in the first place?
For example, it's a very quick. How long? What length the implant you need? Okay.
Again, in the specific edentulous maxilla.
And how many? And if I have a short implant, how short I can allow and can sustain the force?
Yeah.
And what kind of procedure, what kind of occlusion is? I don't think we have an answer there yet.
Yeah.
And even though, for example, I just mentioned about probe, we can really looking into, can we find a way to probe the implant or identify the tool can replace the probing and give you the accurate data.
Yeah.
See, that's also the motivation for people to invent the new idea and new technique.
Interesting.
Maybe this is a component that the listener or the audience has to understand when they look at this guideline. So the traditional way of a scientific guideline is we define the optimal scenario. Yeah, we want to know how many implants, implant length, implant positioning. And this is what we in science transfer into a PICO question. Yeah. So the population is the edentulous maxilla. The intervention is long or short implants. Yeah. And at the end, the question is always the same. Do we have evidence or not? And you spend a lot of time in trying to answer these PICO questions, and you come to the conclusion we don't have the data. So we don't have
Which is frustrating.
Which is frustrating, but this is part of science.
Yeah.
Science is in most aspects frustrating. Yeah, because you always come to the limitations, which is fine. But
because you're pushing boundaries on the other side, depends the perspective.
So, and then comes the question, what does it bring to the reader, to the practitioners, to the patient? If a consensus comes to the conclusion, we don't have the evidence for this, and for this. So we cannot make any conclusions or recommendations. And for the edentulous maxilla, this was so obvious that we will definitely run exactly into this dilemma.
Exactly.
And that's why we changed the methodology. And the methodology was to the survey-based approach. So we asked in surveys experts from different societies on a very comprehensive questionnaire. What are you actually doing? So what is your best practice? What are you doing? So we had a clear picture on what our colleagues are actually doing in their day-to-day practice.
Yeah.
And then we have evaluated if this can be matched with the existing literature. And this was sometimes the case.
Yeah. And in that case, you could quite confidently say,
yes,
this is a best practice. Because we see it in the empirical review.
Exactly.
And we see it in data, although the data might not be big enough.
Match.
Exactly.
Perfect match.
But then.
And most importantly, the things that they are doing, but there is not the big evidence behind. And that was the beauty. For each and every scenario, we could come to meaningful conclusions that can be used. Of course, always under the, let's say, the clear remark, this is not supported by our standard evidence.
But I can imagine this then automatically creates a very clear research agenda.
Yeah.
Right? Because you now actually know what is the mostly common best practice out there. So that's the first thing you want to validate, right?
Yeah. And the funny thing is, we expected that some procedures that they or we are doing are even contradicting the literature.
Oh.
This could also be a scenario.
Yeah.
We are doing a procedure.
But if that
the
happens,
literature
Frank
says-
Hom-Lay, what does the GCCG do with that?
Well, we could not exclude that this will gonna happen, right?
So it hasn't happened yet.
It hasn't happened.
No, but
It
in the
hasn't.
methodology that
In the
could
methodology,
happen.
that would have been one possible scenario.
Okay.
Yeah.
Okay.
It can happen, but it's not happened yet.
Good for you. Good for you. And from that answer, Hom-Lay, we can already detract. There is a broad and perhaps long future for the GCCG because now you focused on one specific set of cases, edentulous maxilla. Have you already identified what the next topic would be that you would work on? I know this is early because you've just released the first one, but what does the future hold?
I think we talked about the focus on the maxillary anterior area with single implants for the aesthetic and bone.
To be super clear, in September 25, has this been decided or this is what you think?
I think it
has been
it's-
decided.
It has been decided.
It has
Okay,
been
yeah.
decided,
So we
and
know what the next
in a
guideline
very
will be.
democratic way. Yeah, we have raised the question to all the experts on site, and they could vote.
Aha. I just want to make sure that we decide facts from opinions, which are both valuable.
I
But
mean, logically, and this was one of the questions coming from the audience today. What about the mandible?
Yeah.
We have the edentulous maxilla. What about the mandible?
Yeah.
And we had the mandible also as one option.
Yeah.
But it was not rated
and
first.
number one is a
Or
number
not.
two.
It was
Exactly.
number two.
Exactly. So that will be the third global guidelines, perhaps,
Perhaps.
if it survives the next one.
Perhaps it depends on the people who vote on it, and then
On the next one,
on the next
so it's
one.
a very bottom-up and a very together
Democratic.
effort.
It's a democratic, yes.
Yeah.
Only that's
Yeah.
what we want.
that's what the beauty is.
It's good to
It's
understand.
not just us that dictates, and we don't select the expert to do. We do in the survey, we ask in the organization, identify people who had expertise in the field.
Exactly. Now, on stage in this plenary session, you had some of the chairs of the working groups going through all the different steps of the workflow. It's a very dynamic, short presentation style session. So I think you will be interested to watch that. Before they go over and watch the entire session, any final word you want to add to this conversation, Hom-Lay?
I'd like to thank everyone, especially Frank and also Ronnie, and certainly the scientific task force, and also these 4 outstanding working group, the writers and their presenters. And without them, we don't have a GCCG. And the ENA Corp also helped to moderate the session. So, we're very lucky with the supporter from Lisa Heights Mayfield from COI and the publisher. So I think we are here for blessing. And my advice to the readers or to the audience is read the paper, at least umbrella paper first. And then you learn what is inside. Then you can make your opinion. Don't judge it until you read it.
Nice. That's a very clear takeaway. Frank, final word from you?
Yeah, the final words go especially to the people that are not in the forefront. So you need people that are working in the back office to organize the logistics, also the, let's say, press releases. There are so many tiny little bits that you could not even imagine beforehand that would gonna happen. Yeah. So, and that's why they are all acknowledged, duly acknowledged in the paper. So that's why they should also be high up.
Exactly. A lot of rounds of applause. Well, the fact that you are still watching this video means that you have a high interest in this topic. So first of all, if you're now watching this on Monaco Online, you can go into the recording of this full plenary session and even dive deeper before you start reading that entire paper and get more curious. And if you've already watched the session, be aware that there's many more of these Let's Talk sessions and other educational scientific content around. So keep watching and keep learning.